I'm Sammi. I'm a mum of two. I've got two young girls who are 2 and 5. And unfortunately, I'm a patient that's had sepsis in the past.
And my name's Dr. Andrew Conway Morris. I'm the Charity Medical Director for Sepsis Research FEAT, and I'm also a practicing intensive care consultant in Cambridge. So, Sammi, could you tell our viewers about your sepsis story? How did it all start?
Yes, so it started in March 2023. I was pregnant with my second child. And at the time, I was probably about 6 weeks pregnant when it started. So started quite normal with just a cold, and it lingered. It lingered in total for around 3 weeks. After about a week and a half, it seemed to be turning into a chest infection. So I went to the doctors to seek some help and asked for antibiotics. And at the time, I was told, that you don't really want to be taking medication unnecessarily because of the pregnancy. So try and see if you can fight it. Lots of liquids, paracetamol, you'll be fine. It didn't get better. So it continued. I tried again, was met with the same response. And then on the day that the sepsis was diagnosed, I was at home. I actually felt pretty okay in the morning, and I think that's where I realised that something wasn't right. In the morning, I woke up, felt quite unwell, but went on my laptop in bed, working from home. At the time, I was in banking. And as the day progressed, I was getting more confused. I was getting really, really lethargic, and I was feeling colder and colder. I actually said to my colleague at the time, I think I'm going to take a bit of a break because I'm just don't feel right.
Yeah.
Called my husband from downstairs and said, can we take my temperature because I don't feel good? And my temperature was over 40. So at that point, we decided to call 111. Luckily, 111 took the situation quite seriously. They sent an ambulance car to the house. When they arrived, they did an ECG. They took my temperature and they did say to me, they said, something is wrong, but we're not quite sure what. An ambulance could take quite a bit of time, to send a proper big ambulance. I don't know the right word.
Proper big ambulance.
Proper big
good,
ambulance.
Yeah.
And so you should get yourself to A&E pretty quickly. When I arrived, I was getting more and more delirious. I was just sweating insane amounts. I think they could see upon presenting that I was quite unwell visibly. They were trying to put the ECG stickers on and they were just slipping off. So it took them quite a while to get a reading. And from the vitals, they said, again, you need to be seen pretty quickly. There were no beds available in resus at the time. So they took us kind of into a side room and took a blood test. And it was there that the doctor said, we're going to start treating immediately. We think that you have the start and onset of sepsis. We're going to start treatment for that straight away, but the blood test will come back and confirm, and we'll need to do an X-ray. And that's how it started.
Okay. And then once they'd started the treatment, so they were presumably giving you antibiotics and so forth, how long before you started to feel any better?
So luckily that time, by the next morning, I would say I felt quite a lot better. So I had to do, I've lost my trail of thought now.
That's all right, no, take your time.
So they took me through, they put me onto liquids and IV antibiotics. And after, I think, a couple of doses of that by the morning, to be honest, I was feeling a lot better. And they said I could go home with oral antibiotics for a week.
Okay. So in that situation, obviously you were very unwell when you arrived in hospital, but you turned around quite quickly with the appropriate antibiotics. What was your sort of, you were describing how you felt at home. Do you think there was a real sort of difference between how you'd been the day before and the sort of that period leading up to the day when you became severely unwell?
I think the main thing, you just, and I've had it in both experiences, you get this real deep sense of doom. You just feel like something's really not right, and your gut is telling you, this is the most unwell I've ever felt. This doesn't feel like a normal cold anymore. It doesn't feel like a normal chest infection. It turned out that when I got to hospital, it had developed into pneumonia, and I think that's what had started the onset of sepsis. But I just felt absolutely terrible. You know, I was short of breath, sweating, felt very cold, but actually my temperature was really high. And just, overall very confused, but very zoned in on the fact that I was very unwell.
Yeah. And if it's not going to put too much strain on your marriage, how did your husband respond to this?
I think we were quite shocked. So at the time, I'd been ill for a few weeks, and I think sometimes in early pregnancy, you know, people around you can think, okay, how long are we going to milk this pregnancy situation? It's true. And, you know, and the tiredness and the fatigue, and okay, you've got a cold, but, you know, kind of get going. But that day he said to me he did notice that something was really not right. I did not look very well at all. I was very pale. My skin looked strange. And yeah, I normally crack on with things. And I think on that day, I just couldn't do anything. So yeah, in the hospital, when they said that they were treating for sepsis, he was quite worried. And I think he was worried for me, but also for the pregnancy.
Of course.
Because it was in the early stages.
Yeah, absolutely. And I mean, I think it's fascinating the way you describe that story, because it's in some ways so classic for sepsis. You know, often starting with what appears to be a completely innocuous infection. I suppose the question to ask you actually is, did they ever identify a bug or a cause there?
Not from what I recall. I don't know if it was viral. I don't know if it was bacterial. I can't remember, to be honest. But I remember that they did the chest x-ray, and that's where they saw the pneumonia in the lungs, and they said that was the cause of the sepsis. They just said that the blood test that they did, I don't know if it was gases or something, confirmed that they'd caught it just at the right time. I remember them saying that.
Yeah. Because I mean, I think particularly, obviously, respiratory infections are very common, particularly as causes of sepsis. They are the commonest cause of sepsis, and as you say, you know, they can be caused by lots of different things. Viruses very commonly, and then bacteria less commonly. But sometimes what you see is somebody has a viral infection first, and then that leaves them a bit more susceptible, and then they get a bacterial infection, sort of what we call a secondary infection. And it's often that secondary bacterial infection that makes you really unwell. Obviously, with your case, it's difficult to be certain without having a time machine and be able to go back. But the story would certainly fit with having had a viral illness which goes to your chest, and then you develop bacterial pneumonia, which then drives the sepsis response. And as I say, I think your description of it is you know, I hate to say textbook, but it really is that sort of, you know, feeling more unwell than you've ever done before. And I think for those who are watching this, that probably is the most important sign. You know, sort of trust your own body. And I think also your husband's response is also, you know, you don't look like you normally do when you're unwell. You know, we obviously have our loved ones around us. They get to know us, our foibles and all the rest of it over many years. But they also know what we're like when we're all right, and when we're having, as my wife would call it, man flu, and then when you're properly unwell. And that's so important. And you'll also know as a mum, you know, with your children, again, you know, they all get unwell, they all have temperatures and can be cranky and so forth. But there's definitely a difference between the sort of, you know, cranky, snotty toddler and the properly unwell one. And obviously, what you did was absolutely the right thing, which was seek medical attention. And you're right, unfortunately, ambulances are not always immediately available. And I think the advice you got from 111 was you know, probably very sensible and got you there in time. Because once that sepsis has set in, the window of opportunity for treatment is narrow. As I think your case demonstrates, though, if you get the right antibiotics in, you know, at the right time, actually the turnaround can be, not always, but can be quite rapid, which is, you know, reassuring, and obviously as a doctor what we like to see. It doesn't always happen, as you know from other experiences, but you know, so I think, you know, what you described there, and certainly for anyone listening, those are definitely the things to look out for. Now, obviously, your experience was there in early pregnancy. And women who are pregnant are at increased risk of sepsis, unfortunately. And that happens throughout the pregnancy, from the early stages right through to, delivery at the end and the period afterwards, the sort of postpartum period. Your experience isn't unusual. Pneumonia is, still remains the commonest cause. But obviously women who are pregnant also have, issues that are specific to pregnancy.
Yeah.
So you have the fetus and the placenta, and both of those, the space around the fetus and the placenta, can become infected. After delivery, obviously people who've had operative deliveries, so cesarean sections or instrumental deliveries and so forth, there can be infections developing around there. But again, it's still mostly infections elsewhere. It's the chest infections. And during COVID, we saw a lot of in large numbers, but they sort of stick in your mind as sort of prominent cases of ladies who were pregnant who then developed severe pneumonia and then ended up in intensive care.
Yeah.
I think, as you say, often, amongst the concerns, obviously the concern for the mother, but there is also the concern for the baby.
Yes.
And for the pregnancy, and that every case is an individual one. Obviously, infections put a real stress on the body. Your body's always sort of initial response is to protect the body itself, sometimes at the expense of the fetus. And there are times when the medical team are in a real dilemma as to, is this pregnancy still viable? Can we continue? And will continuing endanger the health of the mother? Which obviously, nobody wants to lose a child, but we certainly don't want to lose mothers as well. There's some interesting questions around what are the effects of having been septic during pregnancy. What are the effects on the developing child? And I think it's always difficult to disentangle because there's so many different things that can occur during a pregnancy. If a pregnancy is progressing after an episode of sepsis, is progressing normally, the fetus is growing at the expected rate and so forth, then you may say, well, there probably hasn't been much effect, but it's very difficult to tell, and they may be more subtle effects.
Yeah.
I think certainly we know with children, once they've been delivered, those who get severe infections early on in life, and particularly those who end up in, say, paediatric intensive care, often do have longer term sort of neurocognitive changes and so forth. And so some very interesting thing that I read recently about the importance of birth order. So children who are the sort of second or third, much more likely to end up in hospital with an infection than the firstborn, because the firstborn brings the infections home. So
that's true.
So and that does appear to have some effect on sort of cognitive development. Now, obviously, that's different from maternal sepsis, because in that case, the infection happens whilst the baby's within you. Yeah. But whether that has some longer term implications, I think the answer is at the moment we really don't know. And I think on balance, in situations such as yourself, where you got better quickly and you didn't end up in intensive care, you didn't require mechanical ventilation and so forth, likely that the impacts will have been minor to undetectable. But obviously in more cases which progress, that may not be the same in every situation. Yeah. So I think you had some questions around perhaps management of sepsis and so forth, and the context of pregnancy. Should we get into some of those?
Yeah, I think my main one was, I wonder what would have been different had I been prescribed antibiotics when I approached the GP. I understand it's difficult because obviously they don't want to prescribe antibiotics if it's a viral infection, and the sepsis could have come from a viral infection at the outset. But from my other experience, where I spent a long time in intensive care, the amount of work it takes to undo the damage of sepsis setting in, I wonder what the resistance is to give antibiotics to pregnant women, and if there is any truth in, is there any downsides to pregnant women taking antibiotics?
Absolutely. So really good questions. And I would say that actually this gets it to the heart of sepsis more generally. This is not just about, the maternal situation, although obviously in that situation we have two patients to consider. both the mother and the child. So I guess the first thing to say is that we always have to remember that in retrospect, things are more clear than they are at the time. So looking back, and you can say, well, given where I ended up, had I had antibiotics earlier, would that have prevented, what might have been an incipient bacterial infection? As I say, difficult to tell at the time, and even now in hindsight. But exactly that, it has, as they say, 20/20 vision. And we do, in some ways, have to put ourselves back in the moment and say, when I presented like that, or when I was seeing my general practitioner at that point, could they have known that this was going to develop? And I think the answer is, unfortunately, no. Now, I think the answer is no at the moment. Now, something that, as a research charity, we're really interested in is developing diagnostics that would allow us to predict how things might go in the future and to pick things up even earlier. So before you get to the point where you were of feeling, more unwell than you'd ever done in the rest of your life. Those tests, there are a variety of sort of research projects that are engaging in this area. None of them are really close enough to the clinic for us to be able to say, well, there's your answer. But they are progressing through. And what we would really like to see, and we engaged in the sepsis research prioritization exercise a couple of years ago with the James Lind Alliance, and one of the priorities was, how can we diagnose things earlier in the general practice, in the ambulance, as you come through the door of the emergency department. And it sounds to me as if when you came into the emergency department, you were obviously pretty unwell, and that was recognised quickly, which is great. It isn't always the case. And I would say in the vast majority of times when it's not picked up early, it's not through any lack of attention or understanding of the healthcare professionals, it's because it is genuinely difficult to see, and it may present like other things, trying to distinguish between an uncomplicated infection and sepsis can be a challenge. So if we had tests that could allow us to do that, that could make the difference. And then we could say, well, you're a group of people who definitely should get antibiotics. If we think it's a bacterial infection. Obviously, again, as you say, quite rightly, if it's a viral infection, antibiotics aren't going to do anything. There are some antivirals for some specific viruses, but the impact that they have on people who are otherwise fit and healthy is, I think, fairly unclear. Antibacterials, so antibiotics, absolutely do. And coming back to that issue of why not just give everyone who comes into the GPs antibiotics, well, as you say, first of all, there is the resistance issue, and we do need to be aware of that because, the rates of antimicrobial resistance are going up, and if we don't do anything about it, we will lose those antibiotics. That's a real tension between society and the individual. You say, well, okay, of course, I want us to all have antibiotics in the future and so forth, but this is my child, this is my wife, this is me.
And I need it now.
I need it now. So that is part of the tension, but that isn't the only tension, because antibiotics themselves are not completely harmless. So even for the individual, even if we leave aside the wider societal risks, they come with risks of adverse side effects, sometimes allergies, and there is evidence growing that when antibiotics are used inappropriately, so when someone doesn't have a bacterial infection, their mortality, their risk of death can be higher. Now, obviously, that's talking about a sort of not people who are presenting to general practice with those sort of situations, because obviously their risk of mortality is already very, very low. But certainly patients who are in hospital, patients who've had cancer treatments, and so forth. If you give antibiotics when there isn't infection, then you may be doing more harm than good to the individual. So again, it comes back to, well, could we have a better way of spotting who needs them? And that's where we need the research. That's absolutely it. And so I think you landed right in that dilemma, and I can just imagine how your general practitioner saw you, thought, this is almost certainly not a bacterial infection, and you're not that unwell. And lacking a crystal ball, couldn't see what was going to happen. But obviously, in retrospect, and I'm sure when heard your case, thought, as doctors, we all tend to, reflect on the cases and go, oh, would I have done something differently, in the future? of course, they have to balance that against not then handing out antibiotics to everybody coming in with a bit of a cold sort of thing because my last patient developed severe sepsis. So it's a real challenge.
Yeah.
It doesn't make it feel any better for you, I appreciate.
I understand. I do understand. And do you think, I remember from my own maternity appointments, when you speak about certain risks to look out for, they talk a lot about the baby. So I remember, they have a checklist in front of them and they'll say, if you ever experience reduced movements or anything like that, it's really important that you seek medical help. I don't ever remember sepsis being flagged to me. And I wonder if that could be really useful as part of their checklist for prenatal appointments, but also, on discharge from hospital, if there's any signs of infection, any red flags.
Yeah. No, I think you're right. I think it is important because it is very often the patient themselves who picks up the signs. It's perhaps a little different when people are in hospital and there are lots of people around and so forth, although perhaps not as many as we might like. And then there's sort of close monitoring and so forth, or at least some monitoring. Whereas of course once you go home, it's you and you've got to rely on yourself. Obviously, we think that everyone in the community should be aware of the signs and symptoms of sepsis, and you made such a clear description of those. So I think anyone who's wondering what the signs and symptoms are to look out for, if you've had anything that sounds like what you described, Sammi, that's what to look out for. But I think you're right that there is something to be said about using the pregnancy, first of all, to say you are at increased risk because your body is relatively immunosuppressed while pregnant. You are slightly more at increased risk of infection.
And that's something I didn't learn until I was in the situation. I remember quite vividly in the hospital them telling me that, the doctor saying this has happened because it's likely that your immune system is slightly suppressed. And that's something I wasn't aware of until it happened.
And I think it's something that's not sort of widely discussed and so forth. Obviously, when you're carrying a child, your body can immunologically see it as a foreign body. And so you do need, you've obviously got the placenta to separate you from the child as well, but you do need a degree of immunosuppression, at least we assume that's the reason, to prevent rejecting the child in an immunological sense. And so that does manifest itself. But I think, so the two bits is, women who are pregnant are at increased risk of infections, and they probably are at increased risk of sepsis, which is that progression from an infection to a more severe sort of situation. So that's one reason to flag it up. Is also, it's a moment of healthcare access. It's sort of a time you've got a captive audience. So we should be telling you about signs and symptoms of sepsis. We obviously have to balance that against not terrifying everybody.
Yeah.
And it's hard to come by secure numbers of the numbers of cases of maternal sepsis every year. We know, obviously, the small but awful number who die, and that's typically sort of 15 to 20 a year. That's 15 and 20 too many. But in the grand sort of numbers of ladies who are pregnant, it's a relatively small proportion. Obviously, the proportion who get sepsis and recover, like yourself, is much bigger.
Yeah.
Even then, probably our best estimate is maybe 200-300 patients a year will be admitted to an intensive care unit with sepsis, so pregnant patients. So, across the UK, that might only be 1 or 2 per unit per year. Obviously, not everyone ends up in intensive care when they have sepsis, and it's important to remember that sepsis can be managed outside of the intensive care unit, and often is. So probably best estimates maybe 750 to perhaps 1,000, depending on quite how you define sepsis, patients a year of 600,000 ladies who deliver a baby, and of course pregnancies are more than that number. And again, there's not great numbers on how many people are pregnant because we're good at picking up people once they've delivered babies or once the pregnancy progresses. But yes, it's a problem. Yes, it's something that healthcare professionals need to be aware of, and particularly those who are working in maternity services, and mothers need to be aware of. But we also don't want to, spread undue anxiety, and for people to think that every time they're getting a cough or have a fever, goodness, is a sepsis.
It's the worst case scenario.
And that's a as a charity who are trying to raise awareness, that's a tricky balance to
Yeah.
hit. You know,
It's
we
true.
don't want to overdo it, but absolutely don't want to dismiss it. I mean, that's why we're here.
Yeah, and I think it's difficult as well because in the postpartum period, you know, it's just the maternal instinct. All you think about is the baby, and you might have a cold or you might have an ache, and your priority of your own health just kind of drops and drops and drops, and you're so focused on the baby and its survival that you can kind of forget to look after yourself. So I wonder if that's perhaps.
I think that's very true, and I think that extends beyond just sepsis. I think to sort of general health. You know, coping with the fatigue, the tiredness, the sleep deprivation. You know, the adjustment to suddenly having a child and so forth is major. There's sort of significant psychological and sort of mental health changes around that time as well. And I think you're right. We often, you know, assume that because pregnancy is natural and vital to the continuation of the human species and so forth, that, and obviously everybody loves a baby,
Yes,
you know, and therefore it must be, you know, everything must be great. And we sort of sometimes, I think you're right, downplay some of that. And we should be, you know, we must take maternal health seriously. And obviously there are, you know, large groups of people who do that. You know, and we have systems of, you know, obstetricians and midwives and, you know, the community supports and so forth. But I think, you know, we all know that they're not always as, you know, well resourced as they could be. And perhaps there's not always the focus there that we could all benefit from.
With sepsis, do you see that it's more common in ladies that have had C-sections or surgical deliveries as opposed to natural delivery? Because I remember you said that respiratory illness and that kind of illness is one of the main reasons that pregnant ladies get sepsis. But how about postpartum?
So postpartum, obviously, you've got this sort of mixture of what you might call, you know, sepsis that happens to non-pregnant people. So chest infections, urinary tract infections, pyelonephritis and so forth. And then you've got infections that are kind of specific to the obstetric population, the postpartum population. And those are, you know, infections in the womb. And that can happen however you've delivered. And then obviously wound infections, specific really to people who've had a surgical delivery. So if you haven't had a surgical delivery, then you won't have a wound infection, but that doesn't mean that you're not going to get sepsis. I don't think there's any good evidence that ladies who've had an operative delivery are at increased risk of infection at other sites, so chest or kidneys and so forth. But obviously they are at risk of those infections at the surgical site and so forth. And of course, one of the concerns is that one of the symptoms of infection is pain. And of course, surgery, it damages tissues, it can be painful. So how do you distinguish between the pain you might expect after an operation and pain when it seems disproportionate? And I think, again, that's difficult. I think, as you were saying earlier, you know, and again, it's not just when people are pregnant, but we all have different thresholds. And people may be tempted to say, oh, you're just making a fuss. You know?
It's true.
And at that point, again, I think, you know, trust your instincts. You know your body. And also trust those around you. Because they may be saying, and I think especially at that time, as you're saying, after the delivery of a child, when you're sort of focused absolutely on them. And not thinking about yourself. Sometimes it's those around you who say,
definitely.
You're looking a bit peaky, you know, are you sure you're okay? And try not to dismiss it. And if they say, I think you should go to hospital, you know.
What would you say are the early warning signs that can be missed or dismissed in postpartum women?
So I think, you know, the early warning signs in ladies who've been pregnant are really very similar to those who are not. So, common or garden sepsis, if you like. So the things to look out for are confusion, feeling very, very unwell. So as I say, more unwell than you've ever felt before. Having a high temperature, but also very low temperature as well. A fast respiratory rate, so breathing fast. Cold hands and feet, particularly if that's associated with mottling. or with a high central temperature. So if your hands and feet are very cold, but your temperature is sort of central temperature is high, not having passed urine, and we generally say if you haven't passed urine for a sort of 6 to 12 hours, that's unusual. And those are really the sort of main things to look out for. I think the other symptoms to be aware of is obviously things that may arise from where the site of infection is. And so generally, if you're talking about chest infections, we're talking about cough, chest pain, maybe mucky spit and so forth. If you've got urinary tract infections, then pain on passing urine, pain up in the loins and so forth. With postpartum, obviously there are the specific issues around the womb, and if one's had a surgical delivery, then the surgical site. And things to look out for there are pain, redness if you've got a skin wound, and you'll always get a little bit of inflammation around a skin wound, that's natural, but if it's getting really red, or if you're starting to see discharge either from the womb or from the wound and so forth, and if that looks like pus or it's offensive smelling and so forth. So those are really the kind of things to look out for. And all of those, I suppose the sort of site-specific ones are quite specific, if you like, that's sort of to that particular site. But the rest of them are all quite non-specific.
Yeah. And
actually, you can get those sorts of features in all sorts of other illnesses. But it's not good, but the side of it is that they're really symptoms of sort of generally being very unwell. And if you're generally very unwell, whether it's sepsis or something else, then you should go and see a doctor. So if you have those sorts of symptoms, yes, that might be sepsis, and it's worth thinking, is this sepsis?
Yeah.
And similarly, when you present to a healthcare professional, it's never a bad thing to ask, could this be sepsis?
Yeah.
Because sometimes we all need a little prompt. But they're not absolutely specific. So I think if we think of, say, a heart attack or a stroke with a heart attack, we all know you get
classic signs.
Chest pain and pain running down your arm, or you have a stroke, you're sort of weak on one side and can't speak and so forth. Sepsis doesn't have that sort of very specific, oh, that's definitely that.
Yes.
It's more of that general unwellness. And as I say, if it isn't sepsis, well, then it's probably something else serious.
Yeah.
So you still want to go and see a doctor. So,
yeah. And what's the quickest turnaround for tests to identify if it's sepsis and then get the appropriate treatment?
Yeah, so that's a very good question. It depends sort of what tests you're talking about. So there are tests that you can do in the emergency department that will give you an answer within a couple of minutes. Now, they tend to tell you that there's something wrong, but not what's wrong.
Right.
So you mentioned earlier blood gases. So that's a test that's often done, and the range of actually tests that can be done on that test have got bigger even in my career. So you can certainly look at how much oxygen somebody has in their bloodstream and how much of the other gases, the carbon dioxide, but you can also look at the acids that are there. And one that we worry about is a thing called lactate, which you may know, if you go running and your legs start to get sore, that's lactate building up because you're not getting enough oxygen to your muscles. If you run far enough, you'll stop because you need more oxygen. Now, when you have sepsis, something similar happens. You're either not getting enough oxygen to the tissues, or actually, more commonly, the tissues aren't handling it properly, and then your lactate goes up. So that's a very useful sign, because elevated lactate shouldn't happen. We shouldn't see it in the blood. And so if it is high, it's a warning sign, but it doesn't tell you that it's sepsis.
Yeah.
There are other tests that one can do. We can look at the white cells in your blood, which fight infection. They go up in sepsis, but they also go up in other conditions. And then there are some other tests. There's one called C-reactive protein, or CRP, which does go up again in infections and in sepsis, but again goes up in other things and tends to go up a bit later. It sort of lags behind. And then the other test that we do sometimes use is a thing called procalcitonin, which is a really interesting test because it does seem to be really quite specific to bacterial infections. So you think, oh, maybe we've solved the problem. We've got procalcitonin. The problem with procalcitonin is that when it's high, you can be pretty confident you've got a bacterial infection. Right. But if it's low, particularly early on, it doesn't rule it out. So it's really good for limiting the duration of antibiotics. We know that if patients procalcitonins are falling fast, that we can shorten the duration of antibiotics. So it's really good for personalising that. It's less clear how good it is at the diagnostic stage. Now, interestingly, there was a study recently from Liverpool where they were doing procalcitonins in the emergency department. This was not specific to maternal sepsis, just any patient presenting with what the doctors thought might be sepsis. And they randomised them to either getting procalcitonin or their standard care. And interestingly, they thought that the procalcitonin might help speed time to antibiotics, get a shorter duration of antibiotics. What they found was that the mortality was significantly lower in the procalcitonin arm. Great, interesting. Not quite what they'd expected to see, but a good thing. But the time to antibiotics was completely the same between the two groups.
Wow.
So a really interesting study, I think one that we still don't fully understand. We think probably what's happening, or at least the authors, this is not a study I was involved in, that the procalcitonin acted as a sort of flag. If it was high, it made people do other things.
Yeah.
They'd already giving the antibiotics early, but they were doing other things, maybe arranging additional tests or maybe admitting to a higher dependency area and so forth. Those sorts of, which they hadn't designed the study to see, so it's difficult to know. So those are the sort of tests that we have at the moment. None of them are perfect.
Do you think there will be a perfect one in the future?
Well, we're working on it. We're working on it. So I think it's the other, I suppose the other side of it is that when you've got sepsis, you've got to have an infection. That's at the heart of it. And so part of it is looking at how the body is responding. That's things like the white cells and the C-reactive protein, the procalcitonin. But the other part is detecting the bugs. And at the moment, most of our techniques for detecting bugs are really from the 19th century. We say if Louis Pasteur was picked up out of his laboratory in Paris and transported into a modern microbiology lab, once he'd got over the disorientation of the time travel, he'd rapidly work out what was going on, because we're still fundamentally using the same techniques. We're growing bugs on agar plates and looking at them and identifying them, and that takes 2 to 3 days. You can't really speed that up very much. That's how fast they grow. And obviously, as you've seen in your experience, we want to know now. We'd like to know what the bug is, what antibiotic resistance mechanisms it has, and we'd like to know that, in the next hour, please. So there are tests that can do that. They're increasingly becoming available. Some of them work on blood, some of them work on the site where the infection is, so getting samples from the lungs and so forth. We know that they work. We know that they can impact on antimicrobial prescribing, what we call antimicrobial stewardship. Interestingly, the evidence that they make things better for patients, do they get you out of hospital faster, do they reduce your mortality, it's not quite there yet, which is surprising, because we might have expected that it would do. And that comes to the heart of it, because you can produce a diagnostic test and it can work in the Ronseal way, exactly as it says on the tin, but it's how doctors and other healthcare professionals interpret that test, respond to it, what they do with it, like our procalcitonin example. Sometimes you have a test that has an unanticipated good benefit, but you can also have an unanticipated negative benefit, or negative outcome. Benefit's the wrong word there.
I know what you mean.
So, this bit is there where it gets really complex, because yes, you need excellent scientists putting together clever tests in labs, and then you need people taking those tests out and checking that they actually work.
You need the right action after.
In patients, but then you need to implement it right. And that's something that I think we haven't got cracked yet. I think in the future we will have, maybe not the perfect diagnostic, because nothing's perfect, but I think we will have better diagnostics. And I think we will be able to, at every stage of that pathway, from presenting to general practitioner or primary healthcare setting, through coming to the emergency department, through, if one is unfortunate enough to need to go to intensive care, to being in intensive care, and afterwards. Because I think that's the other bit, is that sepsis isn't over when you leave hospital. As you unfortunately know all too well, there's a period of recovery and rehabilitation afterwards that can take a long time. And some of that could be done, with our and I'm going to say my healthcare colleagues will wince as I say sort of standard rehab. Andy, he doesn't know what he's talking about. But, rehabilitation techniques that we would use for anyone who's been through a serious illness. But some of it may also be dealing with the residual inflammation afterwards. And so I think we probably will be developing diagnostic. Well, I know people are looking at that, diagnostics for that the post-sepsis syndrome, as it's sometimes called. And are there things that we could do? And whether it's just defining post-sepsis syndrome and saying that's where it is, and there you are on the trajectory, or is it something that we could target with a therapy or something? I don't know. I think we're still at the front end. We're closer to the sorts of therapies we might want to give. At the recovery side, there's a lot of work to be done.
Yeah, it would be interesting to know if there was something you could do during sepsis treatment that could reduce the likelihood of post-sepsis syndrome setting in.
Absolutely. And I think that probably, at its simplest level, it's treating it as quickly and as effectively as possible, and minimising. I think, you'll obviously, unfortunately, had been through 2 sepsis episodes, and maybe reflect on the difference in recovery between those two. And obviously in one, you end up in intensive care, and I suspect that your recovery after that was probably longer than it was after the first one.
Yeah.
And some of that will be the site of infection. Some of that will be the bacteria or the organisms that were involved. Some of that may be, where you are in your life and so forth. And some of that might be genetics, And so all of those bits all building together then produce that picture. But what can we do from the healthcare side? Because obviously genetics we can't really affect.
Yes.
Where you are in your life and your previous experience, again, that's sort of fixed by the time you come. But can we find ways of treating you more effectively, quicker? And I mean, the holy grail, if you like, of sepsis treatment, because as you know, it's the body's severe response to the infection that drives it. What we've been striving for, not hugely successfully, unfortunately, for the last 40, 50 years, is a treatment that can improve the host's response, the patient's response, without preventing the clearance of the bacteria. So it might intuitively, look like, well, we've got this abnormal inflammatory response. What we need to do is give drugs that dampen down the inflammation. Surely that will make things better. And 40, 50 years of miserable failure has taught us that it's not that simple.
Right.
Very interestingly, COVID gave us a real, example here of one of the challenges, in that suddenly we had all across the world lots and lots of people with sepsis arising from the same organism, so the same virus. And so we were able to test at scale treatments that people had suggested might be suitable for other forms of sepsis, and get answers quickly.
Yeah.
And we did. And we found that drugs like steroids could be very effective. So dexamethasone. There are other immunomodulatory drugs that work in COVID, usually in the more severe end.
Yes.
And actually, again, a bit like antibiotics, can be harmful if given to the wrong group of people. So trying to find those groups of people. Now, hopefully, thankfully, we're not going to have another pandemic, so we're not going to have to go through that sort of experience again. But one of the challenges with sepsis is because it can arise from so many different organisms.
Yes.
Trying to work out what might work for that organism at that body site in that person, it's a real complex jigsaw to build together.
Yes.
But that's what we need to do research for, is to try and work out these things and move forward.
So in the first instance with the sepsis when I was pregnant, I think the main concern that I had is just the anxiety that it gave me throughout the pregnancy. I felt that dependent on who I asked, I got very mixed messages on how serious I should take that I'd had sepsis so early on in the pregnancy. Some people were very concerned and suggested, growth scans and, checking on the health of the baby, getting my own heart and things scanned to make sure there was no long-lasting damage. Luckily, all of that seemed to come out okay. So I think that is testament to how early it got recognised and treated. I would say that I struggled more in that pregnancy than in my first. So I do wonder if that was in some way the after effects of having the sepsis, or if it was just, like you say, because it's my second child and I'm just more tired running around after my first. But I did end up hospitalised around 32 weeks, and they thought that she may be coming early, but luckily she didn't. Second time round obviously was very different. And that recovery has been very different. So that's taken a lot of rehab that I've had to try and organise proactively myself. So it's been physio regularly every week, mental health treatment as well, because it was a very, very scary time. And a lot of dietetic support, because I had a lot of muscle atrophy to try and put the weight back on and eat all the calories. And I think that having to do that with a newborn baby, when I think, you know, if some ladies have experienced sepsis in the postpartum period, to have to do that and then look after your children would just be unbearable. You know, since my last bout of sepsis, because I was in hospital for 3 weeks and I couldn't see the children, my relationship with them has been really impacted. So my 5-year-old's been experiencing a lot of anxiety. I get lots of really deep questions about what happened. And there's been a lot of big thoughts and feelings. And we're working on it. And, you know, she's doing talking therapy and the school have been great to support her. But with my youngest, because she was only 2 at the time, or just approaching 2, she's really struggled to understand what happened. So when I did come out of hospital, they were so happy to see me, but I couldn't lift them. I couldn't hold her, comfort her, and do a lot of just the day-to-day things that they expect their mums to do, you know, cook, clean and look after them and take care of their basic needs. And I think that is something that I would really sympathise with for women that experience sepsis in the postpartum period, because it takes such a lot of effort to recover and to heal. And you have to take ownership of it yourself. You know, I found that, and this is no shade at, you know, the healthcare system, but when you're discharged from hospital after something like that, it's kind of, you know, there's your papers, off you go, and everyone expects you to be back to normal because you're no longer clinically unwell. But actually, the toughest part of the recovery is sometimes when you come out. So yeah, that's what I would say on that.
And I think again, your experience is you know, very common. You know, we know that sepsis has effects beyond the patient. It has social consequences within your family and beyond. It's financial consequences. You know, it's affects so many different areas of one's life. And you're right. I think unfortunately the rehabilitation sort of structure just isn't there.
Yeah.
You know, and it's or at least if it is there, it's ad hoc.
Yeah.
And often relies on yourself.
It would be great to come out of hospital with, you know, a clear plan of these are the areas that you need support in, and a referral is going to be in place for you, or perhaps, you know, these are ways you can seek out this support yourself. But if you didn't have that same kind of resourcefulness, or you didn't have that kind of savvy to be able to find that out for yourself, I don't think I'd be sitting here in the position that I'm in today. And again, because we're talking about maternal sepsis today, the thought of that with newborn baby is just, yeah, that's a really scary thought.
Yeah, no, absolutely. And I think it is something that, you know, as a charity, we would, you know, very much like to see more of. And, you know, we're aware that there's government action forthcoming on sepsis. We're extremely supportive of that. But it's got to be along that whole pathway right from the start, but through that long recovery period, so that people don't find themselves, you know, here's your papers, off you go, best of luck. You know, that's not what we want to see. So thinking back, what, you know, as we discussed earlier with sort of benefit of hindsight and so forth, but what do you wish you'd known at the time?
I wish I'd have known that every minute counts. I think that was important. And I think I was very lucky, like you say, on both instances to arrive in A&E and get seen very quickly, and for somebody to pick up and recognise what was going on. But in a situation perhaps where somebody didn't get so lucky, I think the timing would have been so critical. And, certainly in my second instance of sepsis, we waited for an ambulance for quite a long time. And I do wonder if we'd have just got ourselves there, would that have changed how bad things got? So I think that would be great. And for the first instance of maternal sepsis, I think I just wish I would have been made aware of the red flags to look out for. So like I was saying, it's important not to be scared. And I know I absolutely would have been anxious and scared if someone had said to me in my first appointment, you're now at a super high risk of sepsis, and, anytime you get ill, it's going to be terrible, of course. But if I'd have just known a few of the signs to look out for, perhaps I'd have been a little bit more assertive in my approach with the doctor, and things like that. Yeah, I think they're the main things.
Okay. And what would you like to be able to say to other women who've been in your situation, or to other women who are pregnant now, maybe listening to this, maybe, not feeling unwell at the moment, but hearing your story, think, could that happen to me? What advice would you give them?
I think my advice would be that your health is so important. If you're not a healthy mum, and you're not in good health and you're not looking after yourself, you can't bring the best of yourself to your baby. And I think sometimes we sacrifice so much as mums and new mums, and I think it just continues throughout life. My mum always says to me, welcome to a lifetime of worry every time a baby's born. That's her favourite saying. So I think it's really important to prioritise our own health so that we can be in the best health to look after our children. And by doing that, if you do have any health concerns, just make sure you get seen. Make sure you're assertive. Make sure you're not dismissed. I know it's a bit of a, I don't know what the right word is, but I think in women, health concerns can be dismissed quite a lot. And I've certainly experienced this. I suffer with endometriosis, and it's a classic sign that it can be dismissed quite easily. Period pain is normal, or it's in your mind, you're an anxious person. And particularly, I think in postpartum women and pregnant women, a lot of things can be blamed on hormones.
Yeah.
And, it's just your hormones. That's the classic thing that you always hear. But if in your gut something's not right, and like we said, you're feeling more unwell than you've ever felt, or just any concerns really about your own health, make sure that you get seen, and make sure you ask, could it be sepsis, if you've got any of those red flags.
Absolutely. And I suppose the other thing to say with that as well is that if you have been seen and you have been reassured, you can always come back, and ask, I think, before you leave, you think, I'm okay now, what should I look out for? What symptoms, if I developed, would you be concerned about? Should I come back for? And then if those develop, then go back.
Yeah.
I think we always worry about overburdening the NHS, and it is busy and it is under pressure. And as we were saying earlier, we don't want to be scaring people.
Yeah.
But I think probably there is far more of people staying at home when they should be coming in than there is people coming in when they shouldn't.
And people do, even I found some healthcare professionals cared a lot about the baby's health. I remember waiting to find out what was going on, and we were waiting for an X-ray, and a nurse had said to me, are you sure you want to be doing this? There's a lot of risk for radiation with the baby. And the main doctor that was kind of dealing with me heard the conversation, and he said, without mum, there's no baby. So we really need to think about mum right now. And I think that's a good message for pregnant women or postpartum women. Without us, there'll be no baby. So we really, really need to look after us.
Absolutely. I know, I couldn't say it better. I think that's absolutely right. And that's got to be the priority. And as you say, when you have a child, you often don't put yourself in that way round. You often put the child first. That's a natural parental instinct.
Yeah.
But we have to remember that without mum, there's no baby there. So Sammi, why do you think it's important that mums who are pregnant and those around them, their sort of support networks and families, and those who've been recently pregnant, ask the question, could this be sepsis? What's at the heart of that?
I think that it's important to always kind of plant the seeds into medical professionals' heads, because like you said, in these hospital departments, there's so much going on, and it must be such high pressure. And sometimes it might just take that little nudge for somebody's kind of brain to kick in and think, okay, perhaps we should be looking at this from a different angle or do some additional tests just to rule it out. For the support network, I think it's important because, like we were talking about, sometimes it's easy for women's concerns to be dismissed, particularly in the instance of pregnancy and with hormones raging and everything like that. So I think it could be quite helpful for others in the support network, so, husbands, parents, whoever it is that they have there as support, to be present and to kind of advocate for the pregnant person or the postpartum woman and get people to think, could this be sepsis? Because like you said, there's so many things that could cross over and could be thought to be something else. So maybe just by giving that nudge, it might just make somebody think, let's take a different avenue and look at, could it be? And if it is, hopefully treat it very early. And that could be the difference from it coming into kind of the best outcome as possible and getting early treatment and therefore having a good recovery, to someone ending up in the ICU.
Absolutely. I think that's absolutely right. As a busy healthcare professional, you've often got multiple competing priorities. You've got several patients to look after, and trying to keep on top of all of that can be a challenge. And it is relatively easy to get locked into a particular diagnosis. You think, okay, I come in, I see, someone tells me something, someone's handed over, I've got an idea of what the diagnosis is, I know what it is. And then we get not fixated on, but we get sort of hooked on that. And the way to challenge that is someone to say, have you thought about something else? And that might come from the patient, that might come from their relatives and so forth, that might come from a fellow healthcare professional. I think we've all, as doctors, will think of examples where exactly that's happened. Either we've been the one coming in and asking the question, then we feel very clever about ourselves, you see, or often, it's somebody else who said it to us, and you remember, yes, I thought of that earlier.
Yeah.
So having that aware, and of course, from the patient's perspective, your body.
Yeah.
You know what's normal for you better than anybody else. And often you'll be meeting a doctor or other healthcare professional, for the first time.
Yeah.
And that will be it. They've never met you before. They need to try and make a rapid assessment and so forth. So I think, as you were saying earlier, it's important to be assertive. One should never be afraid of saying things and polite but appropriate challenge when you're being told stuff. It doesn't quite make sense.
Yes.
It doesn't, this doesn't feel right. Or, I've had a nasty cold before. This feels different.
Yeah.
Trust me, I'm. And I think again, you're right that in people who are pregnant, it can be tempting to just dismiss the symptoms. They say, well, because pregnancy produces all sorts of symptoms.
Yes.
And you often feel a bit rubbish, in that first trimester, sort of, often feeling quite sick and tired and so forth. And the third trimester, often just feeling, sort of, tired and breathless. And I just fed up, can we have a baby now? And so those sort of symptoms, which of course are not part of your normal non-pregnant life, can, I suppose, mask things. So sort of, I think the other thing with asking the question is it's not just about asking other people the question, but asking yourself the question. Thinking of those symptoms that we've talked about, and then just think, could this be sepsis?
The main message that I would like other mums to know about sepsis and to hear about sepsis is know the signs, know the symptoms, trust your gut and trust your instinct. So, if you feel more ill than you've ever felt, or if it feels vastly different to anything you've experienced before, it could be sepsis. And it happens to everybody, or not everybody, anybody. I think often, pregnant women are young women and hopefully usually quite healthy and fit and in kind of the prime of their life, you could say. So you may not think that sepsis could affect you, but knowing and understanding that because in pregnancy you're slightly immunosuppressed, that could, just having that knowledge might make you think if you do get a cold, or even like you were saying, if you get a slight skin wound that gets an infection or something, you might just keep a closer eye on things. And if things do start to escalate or linger a bit longer, get them investigated.
I think I would agree entirely. I think that's the message: is be aware. It can happen to anybody, even, as you say, women who are in the prime of their lives are not immune, and in fact, as we were discussing, in pregnancy are at an increased risk. It's a small increase in risk overall, but of course, if it happens to you, then it's it's binary. It either happens or it doesn't.
Yeah.
But that increase is definitely there. So that awareness, keeping a closer eye on things, looking out for those symptoms, and asking that internal question: could it be sepsis? And I think the other thing I would say is to tell the people around you as well. So it doesn't have to be just on you. Sort of, I'm feeling a bit unwell. Will you keep an eye out for me? If you start to see these things, because the confusion that you experience,
that's very true,
can get to the point where you can no longer think rationally.
Yeah.
You're no longer able to do the right things, call the 111.
Yeah.
Certainly may not be well enough to drive and so forth. So it's saying, look out for these things, please.
I must admit, just reflecting on what you said, in my situation, laid up in bed, things deteriorating, it was my husband that said about calling 111. And even that in itself is quite unusual. He's normally not that person. But I remember saying to a colleague, I actually made contact with a colleague before logging off and said, they've said they're sending an ambulance. Not really sure why, but, I'm sure I'll be back on later or tomorrow and I'll keep you updated. So that kind of relates to what you're saying about that confusion and not fully understanding. Of course, I felt terribly unwell, more unwell than I had. But at the same time, perhaps there was an element of confusion in thinking, is this really that serious?
Yeah. No, it's having that buddy, I think. And obviously, not everyone is fortunate enough to have people around. Almost everyone has contact somewhere. So even if they're not in the house with you, I think if you're in that situation, you're beginning to feel a bit more unwell, phone somebody and
even
say,
a neighbour or something.
Yeah, and say, listen, if if there's any trouble or don't phone you back or whatever, then do let somebody know, sort of thing. So that if because sometimes it may not be that they're just on their own all the time, but maybe just a temporary thing. People go away and so forth. So reach out, build that support network, and make sure they're aware of the risks.
Mm-hmm. I think the main thing I'd like to see in change in how maternal sepsis is treated or recognised is better awareness throughout pregnancy. Like I said earlier, I think it would be so great in prenatal appointments not to have a scaremongering exercise, but just, as part of their checklist, it would be wonderful to just touch on, your immune system's working pretty hard right now to make sure that your pregnancy is working well and growing well. And during that period, if you do get a cold or a virus or any type of infection and you're feeling very unwell, do get it checked out and make sure you get the appropriate treatment and try and prioritise your health. And similarly, upon discharge from hospital too, that could be really useful. What do you think could be?
Yeah, so I would agree with you. I think, the first step is awareness. I think within the health system, there has been a step change in sepsis awareness over the last, 10, 15 years. I think it's much, much more common. It's increasingly taught in medical school and nursing school curriculums and so forth, and there's a lot of awareness around. But we can always do a bit more. And I think that perhaps particularly in the area of maternity is making sure that everyone's aware that even though most of the time ladies who are pregnant are healthy, pregnancy is a normal process, but there are these risks. there. What I would really like to see, though, is to be able, to have the diagnostic test that we don't have just now. The one that can give you an answer in a couple of hours that tells you what the organism is. Is there an organism at all? Is there an infection or not? If so, what that is, which antibiotic or antiviral you should be giving, and maybe whether you should be giving some sort of host-based treatment and so forth. That's what I would like to see, but that's my wish list, and that's a long way. Some of it's a long way away, maybe 5-10 years worth of research and development away. I think what we can do right now is exactly what you're saying. It's the awareness, it's the processes, it's making sure that people get the antibiotics that when they need them, whilst at the same time making sure that we're not exposing people unnecessarily to them. That the other organ supports that people might need, whether that's fluids and so forth, that they can get them. That if they need access to a higher level of care, like intensive care, that it's there, that there's a bed available.
Yes.
There aren't delays in getting people in. If there are procedures that need to be done, whether that's surgical procedures or drainage procedures and so forth, that they can be done at the time when it needs to be done, preferably in the hospital where you are.
Yes.
Not having to be moved, unless utterly unavoidable. And so that sort of awareness process around what we can do now, all the stuff we already know, we can do, we know all the things we need to do, we just need to do them well. And then looking to the future, my magic test.
Yes, yeah. I think that, just quickly touching on the second time I had sepsis, I think that the length of time that I was in the hospital, a lot of that came from, not understanding the right type of antibiotic that would be effective and that kind of thing. So I think what you're saying about the delays in identifying the bacteria that's causing the infection and what works best against that also really changes the outcome and the situation.
Yeah, and I think at the moment that is, some of that is unavoidable because of the technologies that are there. But in the future, I think that will be something that we can do, a lot better.
Yes.
And it's been, fascinating to watch, to be involved in the development of some of these and seeing how things have changed. Even in, I've now been practicing for slightly over 20 years,
wow.
Slightly terrifyingly, and even in that time, there has been real progress.
Yeah.
And so one hopes that's sustained and continued. But of course, that's only going to happen if we fund the research that we need to do to get this right. And it's sepsis. It's a problem for pregnant women, but it's a much wider problem than that, and it affects so many people. And yet it really doesn't necessarily get the attention that other major conditions, heart disease, cancer and so forth get. Yeah. So I think it's so important that we make the case both as healthcare professionals but also as patients and survivors for why this is so important.
Yeah.